Hello everyone. My name is P.U. Amit Uttam Chandani. I'm MD Homeopath, specialist in PCOS and infertility from India. First of all, I thank Traditional Medicine and Committee for giving me this opportunity. Co-author Aditya Dilip Kumar Patil, who is a PG scholar from Department of Homeopathic Pharmacy, Bharati Vidyapeeth, deemed to be University Homeopathic Medical College, Pune, Maharashtra, India. So let's have discussion on abstract of PCOS. An open-label pilot study of individualized homeopathic treatment, a case study design in polycystic ovarian syndrome. In this abstract, we will summarize the most relevant and recent reports related to PCOS, briefly addressing the pathophysiology of the disease, then dwelling into its diagnostic criteria. Throughout the review, we will emphasize the complexity of PCOS in terms of introduction of PCOS, worldwide prevalence of PCOS, pathophysiology, diagnosis, morbidities, and the appropriate general treatment approach it requires. Let's get scientific. Polycystic ovarian syndrome, abbreviated as PCOS. The polycystic ovary syndrome is a complex endocrine disorder characterized both by reproductive and metabolic disturbance and is the most common cause globally of ovarian infertility. Providing background information on PCOS. Polycystic ovary syndrome appears to be a common endocrine disorder of women of reproductive age. It is characterized by chronic anovulation and hyperandrogenism and can be clinically expressed with hirsutism, acne, or androgen-dependent alopecia. Types of PCOS. We have 4 types of PCOS. First, hyperandrogenism, where you have normal cycle with polycystic ovaries in ultrasound. Second, normal androgens, where oligo-anovulation is found with normal ultrasound. Third, hyperandrogenism, where oligo-anovulation with normal ultrasound. Fourth is hyperandrogenism, where oligo-anovulation with polycystic ovaries in ultrasound. Common age of onset. Common age of onset is adolescence. Common time of diagnosis is 2nd to 4th decade of life. Some symptoms may appear starting at menarche. History of discovery of polycystic ovary syndrome. Stein and Leventhal are regarded to have been the first investigators of polycystic ovary syndrome. However, in 1721, Vallisneri, an Italian scientist, described a married infertile woman with shiny ovaries with a white surface and the size of pigeon eggs. Next, sclerosistic changes in the ovary were described by Chirek in 1844. Next, class description of a bearded woman with diabetic mellitus were described by Akkad and Thiers in 1921. In 1935, Stein and Leventhal described the features of 7 hirsute amenorrheic women based on the characteristic ovarian morphology from histological specimens taken at wedge recession of the ovaries. Paper on 75 women who underwent bilateral wedge resections, nearly 90% of whom begin to have spontaneous menstrual cycles and 65% of those seeking fertility conceived, by Stein, Cohen and Ilsen in 1948. Next, laparotomy and wedge biopsy became the mainstay of both diagnosis and treatment, which were discovered by Goldziher and Green in 1962. The next diagnostic milestone occurred in the late 1960s and early 1970s with derangements in the hypothalamic pituitary axis. Endocrinological criteria were used for the diagnosis, such as elevated LH-FSH ratios. Pelvic ultrasound in 1970s and 1980s, where first abdominal sonography and later vaginal sonography discovered, complicated the diagnosis of PCOS. In 1990, NIH criteria established for PCOS. In 2003, Escher, Rotterdam, Netherlands, consensus on the diagnosis of PCOS requires the presence of 2 out of the following 3 criteria. First, oligo and/or anovulation. Second, hyperandrogenism, clinical and/or biochemical. Third, polycystic ovaries with the exclusion of other etiologies. In 2006, task force appointed by the Androgen Access Society. Conclusion. Thus, it was not until the early 1990s at a National Institute of Health sponsored conference on PCOS that formal diagnostic criteria were proposed and afterwards largely utilized. Many scientists tried to explain the pathophysiology of PCOS and many studies were made. It is now accepted that PCOS is multifactorial, partly genetic. However, a number of candidate genes have been postulated. Insulin resistance has been noted consistently among many women with PCOS, especially in those with hyperandrogenism, but it is not included in any of the diagnostic criteria. Now let's see worldwide distribution of PCOS. It is known that, based particularly on ancestry and geographic segregation, the world's populations vary in physical, behavioral, and social distinctiveness due to natural selection of genes and adaptation to environmental conditions, which then influences disease phenotype. There is emerging evidence that ethnicity is closely associated with PCOS phenotype due to different genetic and environmental propensity to metabolic and hormonal aberrations. As early as in 1992, it was found that obesity and hirsutism are associated with some genetic factors, and consequently, the ethnic background of women with PCOS needs to be considered in studies that investigate the metabolic parameters. A new study has suggested that Hispanic women with PCOS generally present the most severe phenotype both in terms of hyperandrogenism and metabolic features, whereas non-Hispanic black women demonstrate an overall milder clinical presentation of PCOS than Hispanics and non-Hispanic white women with respect to some aspects. Here we have estimated prevalence of PCOS in unselected female population. In white Caucasian females, 5.5% by 1990 NIH criteria. In Black, African American and Afro-Brazilian, 7.4%. In Chinese, we have less PCOS. By 2003 Rotterdam, 5.6%. In Middle East, that is Iranian and Turkish, we have 6.1% by NIH, 16% by 2003 Rotterdam, and 12.6% described by 2006 AES group. Caucasian females living in the US and Europe are less likely to develop PCOS compared with females residing in the Middle East, whereas black women, the majority are African Americans and Afro-Brazilians, tend to have the highest risk of developing PCOS. Chinese women were suggested to be at a lower risk of PCOS compared with other ethnic groups. In general, we would expect that under the same diagnostic criteria of PCOS, Chinese women are at a lowest risk of developing PCOS, and then in an ascending order through Caucasian women and females residing in Middle East, with black women having the highest risk of developing this syndrome. Pathophysiology. PCOS is a multifaceted disease. The best understanding of the pathophysiology of PCOS deals with it as a multifaceted disease involving uncontrolled ovarian steroidogenesis, aberrant insulin signaling, excessive oxidative stress, and genetic or environmental factors. Let's have a look on basic principles of ovary. Ovaries' functional unit are called as follicles, as seen in diagram. Follicle contains an oocyte surrounded by granulosa cells and theca cells. LH acts on theca cells and goes for androgen synthesis, whereas FSH stimulates granulosa cells to convert androgen to estradiol, which drives proliferative phase. Estradiol surge induces an LH surge, which leads to ovulation. After ovulation, the residual follicle becomes a corpus luteum, which liberates progesterone, which drives the secretory phase, which prepares the endometrium for possible pregnancy. Degeneration of follicles results in follicular cyst. Small number of follicular cysts are common in women and have no clinical significance. Studies have given a general understanding behind the pathophysiology of PCOS. In a patient with PCOS, the primary defects are seen with two perspectives in the body. First is insulin resistance, second, relative imbalance in LH and FSH levels. A person with PCOS may have insulin resistance. This means the cells within your body fail to respond to the insulin hormone to take up the glucose for the use of energy. Because glucose is not used up for energy, it results in storage of glucose, resulting in weight gain. Ultimately, the excess insulin within body will cause the ovaries to increase production on androgens. This can lead to anovulation. Furthermore, the two main pituitary hormones, LH and FSH, orchestrate major changes in the body are essential for reproduction. LH and FSH to be in precise balance required to avoid complications. But in PCOS, there is increase in LH than FSH, which produces excess of androgen substrates that elevates testosterone levels, which are associated with excess body facial hair. Furthermore, when there is decreased level of FSH, the ovaries are not stimulated for maturation of egg and eventually no ovulation occurs. This is the reason why women with PCOS have difficulty in conceiving and experience irregular menstruation. Thus, increase in LH, there is increase in androgen, which forms hirsutism and excess of adipose tissue, due to which there is excess estrone and have negative feedback on FSH, due to which there is decrease in estradiol and forms cystic degeneration of the follicles. Clinical manifestations we see amenorrhea because of increased androgen, hirsutism because of increased androgen, there is infertility because of cystic ovaries, obesity, too much of adipose tissue due to too much of estrone. PCOS is associated with type 2 diabetes mellitus because of obesity. Also, there is increased risk of endometrial carcinoma because of high circulating estrone levels. Diagnosing PCOS. Diagnostic criteria of PCOS is formed by three groups: NIH, Rotterdam, Androgen Access Society. As per NIH 1990, must include chronic anovulation, clinical and or biochemical signs of hyperandrogenism. As per Rotterdam 2003, two of the following three must be present. First, oligoanovulation, clinical and or biochemical signs of hyperandrogenism, or polycystic ovaries on USG. As per Androgen Access Society 2006, must include ovarian dysfunction, oligo or anovulation, polycystic ovaries on USG, androgen excess, hirsutism, hyperandrogenemia. PCOS scenario in India. There are few studies conducted in India. Studies done in South India and Maharashtra. Prevalence of PCOS by Rotterdam's criteria were reported as 9.13% and 22.5%, 10.7% by Androgen Access Society criteria respectively. With this prevalence of PCOS, many hormonal therapy are being used for bringing the ovulatory phase back in the menstrual stages. In such therapy, side effects are involved with various secondary complications. Homeopathy in such cases has shown Miraculous results which have brought the ovulatory phase in regulation with the females for the conception. These results are based on the evidence of ultrasonography, scanning, and the hormonal assay. Founder of homeopathy. Samuel Hahnemann, the founder of homeopathy, was gifted in many fields. So far, as we know, Hahnemann is the only person in history to have envisioned an entire system of medicine and then fully developed it into a powerful and practical tool within the span of a single lifetime. The definition of a cure seems simple at first: the disappearance of patient's symptoms. Homeopathy aims much higher than this. Homeopathic remedies improve the patient's life on all levels. The concept of health and healing in homeopathy is based on the energy force within the body called as life force or vital force. Basically, we search for the leakage in their vital force. We look at the whole person who is suffering this leakage and at how the body is expressing it. We address the whole person and not just an organ or a part. Homeopathic medicine stimulate hypothalamic pituitary ovarian axis, thereby strengthens the immune system and trigger natural release of hormones. Homeopathy, the science of nanomedicine with philosophy of holistic healing, is currently being explained as evidence-based medicine. Homeopathy in such cases has shown miraculous results which have brought the ovulatory phase in regulation with the females for the conception. These results are based on the evidence of ultrasonography scanning and the hormonal assay. Homeopathic case taking is an essence of understanding individual and diagnosing his personality and sensation for the prescription of simillimum. As homeopathic medicines are prepared with the method of potentizing 1:9 as decimal scale and 1:99 as centesimal scale, having ratio of drug as 1 part and 9 parts or 99 parts of vehicle used as ethanol. With such serial dilution, the following cases of PCOS have shown an excellent result and economical cost effective for the patients taking homeopathic medicine. Cases. The following cases of PCOS has shown an excellent result and economical cost effective for the patients taking homeopathic medicine. Abstract. Background. Homeopathy seeks to treat holistically. Objective: to determine the efficacy of individualized homeopathic treatment on PCOS. Method: this was 1 year 6 months pilot study using a case study design. Individualized homeopathic remedies were prescribed to each participant for few months to 1 year as per requirement, and case analysis evaluated changes over time. Design: this pilot study used a 1 year 6 months case study design consisting of 10 female participants between the ages of 22 and 42 years. Participants were recruited by means of purposive sampling using community forum postings and online social network sites. Potential candidates were screened telephonically for the following inclusion criteria: females aged 22 to 42 years having missed periods for last 3 months and diagnosed by investigations only. Exclusion criteria included females who have complaints of missed periods but with no investigation and or any homeopathic medication taken within the previous 2-week period. Results: the individualized homeopathic treatment have a beneficial effect on reducing the symptoms and balancing hormones by regulating menstrual cycles at regular intervals. The case study design allowed for qualitative data to be collected. It is noteworthy that all of the participants involved in the study were Indian women from similar socio-economic backgrounds and in close proximity to each other. So let's have a look on some cases treated by individualized homeopathic medicines. Case 1, we have ultrasonography report of abdomen before treatment. Mrs. Kashish suffered from irregular menses since 6 to 8 months with pain in abdomen during menses, having facial hair growth plus mood swings. In report, we can see complex right ovarian cyst. After individualized homeopathic medicine, Patient was feeling better at general level with no pain in abdomen during menses, and both the ovaries are normal and does not show any cystic or solid region as per CNN sonography report. Case 2. Ultrasonography report of abdomen before treatment. Darshana. Mrs. Darshana complained of menstrual period of 45 days with hirsutism since puberty. Scanty flow, difficulty in conceiving, dominating nature, hot flushes from body and temper tantrums were seen. We can see findings suggestive of PCOD in report. After individualized homeopathic treatment, we can see both ovaries are normal in size and shows normal echo pattern, no focal lesions seen. Case 3. Before treatment, Mrs. Neelam complained of menorrhagia since 4 to 5 months, pain in right abdomen, weeping all the time. General health was disturbed. In USG of abdomen, you can see right ovarian complex cyst, likely which is hemorrhagic. After individualized homeopathic treatment, we see right ovary as normal, whereas general health is also improved well. Case 4 is of dermoid cyst. Mrs. Kirti having left dermoid cyst, where irregular menses were seen and pain in abdomen was there. After individualized homeopathic treatment, left ovary measures normal. Case 5. Empty follicular syndrome. Case of empty follicular syndrome where polycystic ovaries with no follicular growth was seen. IVF failed. After individualized homeopathic treatment, we have single live pregnancy report of 11 weeks 4 days. Case 6, we have before and after reports. Before, we can see PCOD. After individualized homeopathic remedy, both ovaries are normal in size. Patient is keeping well. Case 7, where IVF failed due to thin endometrium and anovulation. Before report, we can see endometrium thickness 1 mm with 7 to antral follicles, but no ovulation was seen. And after reports, ovulatory cycle, ruptured follicle, endometrium size is increased up to 6.2. Patient is improving very well. Case 8, case of PCOD, before and after homeopathic treatment reports are seen. Before, both show more stroma and tiny cyst. Both ovaries show more stroma and tiny cyst, suggestive of PCOD. After individualized homeopathic treatment, we see only right ovarian cyst which is functional, improving well. Case 9, before and after homeopathic treatment. Before, we can see mild PCOS changes, and after treatment, normal, both the ovaries are normal in size and shape. Case 10, before and after homeopathic treatment, we see small right ovary with no focal lesion, whereas left ovary shows a calcific 12 mm focal area in it. After individualized homeopathic treatment, right ovary small, left near normal in size, showing a few calcific foci. Results: all participants reported a great improvement in PCOS. Concurrent improvements in menstrual cycle and general health were also noted. Conclusion: this pilot study shows the potential benefits of individualized homeopathic treatment in PCOS. We have reference in this chart. Thank you so much. Have a good day.